Before we get started with the presentations and the brief introduction, I wanted to mention that this session is being recorded. If you do not consent to being recorded, you are asked to drop off the session at this time. Thank you. Welcome and thank you for attending today's webinar. My name is Courtney Wheeler. I am one of the Public Health Program Managers at the National Indian Health Board, and I will be moderating the session today. We're grateful to have Captain Lisa Grohskopf, Dr. Kanta Sircar from the CDC, and Dr. Jorge Mera from Cherokee Nation Health Services. Today we'll be discussing COVID-19 and influenza, what to expect this flu season. This webinar will last 60 minutes, so please be aware that this session is being recorded, as mentioned earlier. All participants have been muted. Please leave yourself on mute unless the presenter specifically asks you to unmute and engage. Please type questions and comments in the chat box here in the Zoom room, and the presenters will take time to answer questions at the end of the session or throughout their presentation if they decide to do that. If there are any handouts and PowerPoints available, those will be shared after the webinar. Please allow us a few days to get those sent to you via email. We also ask that you complete the session evaluation at the end of this webinar. Thank you so much for your participation, and we are excited to begin. I will now turn it over to my colleague, Arjana Marzette, if she would like to say a few words before we begin.
Proceed to the route.
Okay. So we will go ahead and get started. So first, we will have Captain Lisa Grohskopf. She is a medical officer in the Influenza Division at the Centers for Disease Control and Prevention. She serves as the CDC lead for the Advisory Committee on Influenza Practices, Advisory Committee on Immunization Practices, Influenza Work Group. She trained in internal medicine at Yale New Haven Hospital and in infectious diseases at the University of Washington. I will now turn it over to Captain Grohskopf.
Hey there, just gonna get slides here. Okay, hopefully those are visible.
Yes, we can see your slides.
Great, okay, so I'm gonna present updates on a couple of topics today. I'm just trying to get the slides to advance. Hang on. There we go. Okay, so we have updates on a few topics in this presentation. First, just a little bit on US influenza activity. These slides come from CDC's surveillance systems. This maintains a comprehensive layered surveillance system of various aspects of influenza that goes on throughout the year, but is more detailed during the active flu season. Generally, the more detailed reports start in the beginning of October, and they come out every week. And I'm just going to present a couple of slides from there. This information is from US virologic surveillance, and the data here come from National Respiratory and Enteric Virus Surveillance System laboratories and WHO collaborating laboratories that are located throughout the United States. And what those labs do is they send information to CDC every week about the number of influenza tests that were performed, the number that were positive, and for the ones that were positive, what kinds of viruses were seen in those positive tests. And there are two types of labs that contribute data to the system: public health labs that are on the right, and then clinical laboratories are on the left. Week is on the x-axis in these graphs. So each bar represents a different surveillance week. And the left-hand half of the graph represents last season. And then as we move to the right, we're moving into the present day, running until about October 2nd, which was the date of the last report, the data cutoff date. I'm showing this mainly just to indicate that those of you who've seen these graphs know that typically we see a very nice big rounded peak as you move into the weeks that cover January, February of flu season. And for last season, as we know, things were a lot flatter. There wasn't as much flu activity, and there were not a lot of positive specimens submitted through these laboratories. And if you look far off to the right, as we move towards the present day where we are about now, early October, overall specimens are still low. This isn't terribly uncommon for what we might see in early October. Flu seasons are very different. They vary from year to year for how early we see activity. So we can't really predict what the season's going to be like this year yet. And I'm also going to show a couple of mortality surveillance slides. These are the last two surveillance system slides. There are two mortality tracking systems. The one on the left is death certificate data from the National Center for Health Statistics. Those deaths are not lab confirmed flu deaths, but they're deaths for which influenza was listed as one of the causes. After the start of the COVID-19 pandemic, they also began to collect data on COVID-19 deaths from death certificates. You can see the line sort of undulates. Each of those little peaks is a season. The large set of peaks off to the right, where you see several peaks clustered together, represents the 2020 and 2021 period. And the line represents the total number of deaths either due to influenza or COVID-19 as reported on the death certificates. The blue solid color represents those that are COVID-19, whereas the yellow represents those reported to be flu. So you could see we had flu deaths as reported on death certificates relatively dwarfed by COVID-19 deaths last season. On the right, this is mortality data, pediatric mortality data, which has been pediatric mortality due to lab confirmed flu or associated with lab confirmed flu has been reportable since 2004. This graph also represents several seasons starting with 17-18. And the most recent season that we have data for is last season, 2020-21. And you can see one death reported. One is too many, of course, but that's far less than we had the previous season, 1920, where there were 199 deaths reported, which was the highest season on record since the pandemic. So with that in mind, just a few thoughts about what to prepare for this season. We can never predict what activity is going to be like. And while localized pockets of activity in the US tend to begin to crop up generally as early as October, sometimes it's a little later. And right now we're still relatively early in the month as far as surveillance data goes, with the last cutoff being October 2nd. Activity was overall low last year, unusually low. We cannot predict on that basis what's going to happen this season. And obviously, a lot of the mitigation issues that might have been in place last season to mitigate COVID-19 spread could also have prevented some influenza spread. As those things are put into practice less in different parts of the country, we may see more respiratory viruses overall. And in fact, a recent MMWR described how some respiratory viruses, such as RSV, respiratory syncytial virus, are spreading at increased levels now. All of this said, getting an annual flu vaccine this fall is very important to protect yourself, your loved ones, and your community against flu. Next, we have a few slides on influenza and SARS-CoV-2. So it's anticipated that we're going to see continued circulation of SARS-CoV-2 this flu season. So it's pretty likely that both viruses are going to be circulating in the communities throughout the United States. Co-infection with both viruses in the same person can occur. It's been reported. It hasn't been reported a lot, not in numbers that you could do a study with necessarily, but there have been documented cases and case reports and case series in the literature. Because there aren't that many cases to report, the frequency and the severity and the risk factors aren't known, but it's understood that this might result in more severe disease if somebody gets two infections as opposed to just the one. We really have to be thinking about both these illnesses going forward this season. There's lots of overlap in the signs and symptoms. There are some differences with either infection. These things aren't absolute, but there's sort of things that you can think about when you're approaching somebody and trying to determine which might be more likely. Incubation period generally is shorter for influenza, 1 to 3 days versus COVID-19, 2 to 14 days. The period of viral shedding and viral RNA detection and secretions is usually shorter for influenza than it is for COVID-19. Ageusia and dysgeusia and as anosmia, the sort of abnormalities in sense of taste and smell that are seen with COVID-19 are not as common in influenza. GI symptoms like diarrhea can occur at any age with COVID-19, but with the flu, they're far more likely to occur in young children. Other than that, there are a lot of similarities in the timing of onset and the sorts of complications and the sorts of severe disease you could see as earlier in influenza than in COVID-19. High risk groups for influenza and COVID-19 are similar, and young children in both groups, young children for influenza are particularly high risk for flu complications. Next slide. So some of the implications for the fact that we're going to probably be seeing co-circulation of the two viruses this season. In order to distinguish the two in a given patient, you would need to test. Testing is needed to distinguish influenza from COVID-19. Again, there's some clinical clues that might lead you to think one versus the other, but it's not absolutely foolproof. You would need to test to know, and you need to consider influenza virus infection, SARS-CoV-2 infection, or co-infection with both viruses. There are treatment implications for this distinction. For example, we have FDA-approved antiviral medications for flu, and these will have no effect on COVID-19. For example, oseltamivir, zanamivir, baloxavir is another one, and those will not affect anything with COVID-19, but they can be very important for influenza, particularly for some high-risk groups that are at risk of severe illness. And just as a side note, if you see somebody that you think has flu based on clinical sense, you believe that's what they have, and they're of a group that's at high risk for complications, and somebody that you would want to treat for influenza with, for example, also Tamiflu, it's important that you don't need to wait for a positive flu test to do that, and you shouldn't rely on a rapid test result to do that. If you think it's flu, you should treat for flu. You don't need to wait for a PCR to come back for influenza to do that. Corticosteroids may prolong influenza viral replication in the upper and lower respiratory tract. Those are sometimes used for COVID-19, people who are severely ill with COVID-19. It's just to keep in mind that might keep if the person also has flu, that might keep them shedding and having viral replication of flu for longer. Some of the complications of influenza in terms of bacterial infections, such as pneumonia, are generally more common with influenza than with COVID-19. Next, a topic that I think is pretty important to a lot of people right now, co-administration of flu vaccines with COVID-19 vaccines. As we're in October now, this is generally it's a good time of year to get vaccinated against the flu. And we're probably going to have people continuing to get vaccinated for COVID-19 over the course of the next few months. So this is something that is probably going to rise pretty frequently. The ACIP influenza statement, the recommendations on flu vaccinations, cite the current interim clinical considerations for use of COVID-19 vaccinations approved or authorized in the United States. And this is a web page that can be very useful to help answer questions that you might have about COVID-19 vaccines. It's updated relatively frequently as new information and new recommendations and guidance become available. This page says that COVID-19s can be administered without regard to timing of other vaccines, so you can give flu and COVID-19 vaccine together. The document lists some guidance for situations where you do co-administer. Vaccines, for example, that are given at the same visit should generally be given at different sites, separated by an intramural if possible, which is common guidance when you're co-administering injectable vaccines generally. And it contains an additional piece of guidance that if you're giving COVID-19 vaccine at the same time as another injectable vaccine that might be more likely to cause a local reaction, for example, adjuvanted vaccines, we have one adjuvanted flu vaccine or the high-dose flu vaccine, try to administer in separate limbs if possible. This is guidance, again, this particular page, the interim clinical considerations, that is updated relatively frequently. So I would recommend checking it frequently for any updated information that comes along. So next, some updates on the ACIP influenza recommendations. The ACIP flu statement came out in August, and the core recommendations unchanged, and that's that annual flu vaccination is recommended for all persons 6 months of age and older who don't have contraindications. The document this year contains updates on a few topics, some of which we'll go over in a bit more detail in the next few slides. One is the influenza vaccines expected to be available, the US influenza vaccine viral composition for this coming season. There's a change in the FDA-approved age indication for Flucelvax quadrivalent, which is the cell culture-based inactivated influenza vaccine. We won't go into this in more detail in the future slides, just want to mention that it was previously approved for 4 years and older, and now it's approved for 2 years and older. There have been changes in the timing of vaccination language. Most of them are with regard to people, which groups should be considered for early vaccination. What we consider early is July and August. We're not going to spend a lot of time on that today, only because July and August are past at this point, so it's not too relevant for right now. As we just mentioned, there's now guidance for co-administration of flu and COVID-19 vaccines. That's also reflected in the guidance. And finally, there are some updates to the contraindications and precautions for flu vaccines that are very specific to a small group, and that is people who have had a severe allergic reaction to a previous dose of an influenza vaccine. We won't have time to go through that today, but there are details in the ACIP influenza statement text and also in tables 3 and 4 in that document. So first, just a quick check on the vaccines that we have available. That's the first update for this season. There are a total of 9 influenza vaccines that are anticipated to be available for this season, 2021-22. And what is new about this season is that all of them are quadrivalent. Last year, we still had 1 trivalent vaccine left. This year, everything is quadrivalent. The last of the trivalents have been phased out. So all of these are vaccines that contain 4 viruses, 2 influenza A viruses and 2 influenza B viruses. Chances are you will not have, wherever you're practicing or working, you won't have all 9 available, because generally there are just there's a few options available in any given practice setting. But just to keep in mind that an age-appropriate vaccine should be used, and some of these are available or approved for relatively restricted age groups. For example, Flublok, the recombinant vaccine, is 18 and older. FluMist is only for 2 through 49 years. And Fluad quadrivalent and Fluzone high-dose quadrivalent, those are approved specifically for people age 65 and older. The next update, influenza vaccine virus composition. Just to quickly note here, in general, we usually will have a change in at least 1 strain in the vaccine every season. Every once in a while, there's no change from one season to the next, but that's relatively uncommon. And this season, we have changes in both influenza A viruses, the AH1N1, PDM09, and the AH3N2. Timing of vaccination, we won't spend too much time on, because again, most of the recommendations that are new this season discuss early vaccination, that is in July and August, and now we're in October. But just a note about timing and why it's difficult to predict the ideal time to get vaccinated each season. One of the main reasons for this is that the timing of the onset and the peak of the flu season varies from season to season, and even within a season, it can also vary substantially geographically. We often see isolated pockets of activity start to crop up earlier in some parts of the country than others before things get a little bit more widespread. Generally, in the United States, localized areas of increased activity occur as early as October. In addition to the start of the season varying, the peak of the season also varies. And this little graph is from one of the web pages about the flu season that's on the CDC web pages. And you can see that for the 36 seasons depicted here from 1982 to 2018, February was the most popular month, with a peak occurring in 42% of seasons, but we had nearly 20% of seasons peaking in each of December, January, and March. So all of this points to making for some difficulty predicting each season exactly when the best time to get vaccinated is. So some of the factors relevant to the timing recommendations, unpredictability of timing of the flu season, as we mentioned. There's also been documentation in the literature that flu vaccine effectiveness can decline over the course of a season. This is something that appears to be more pronounced in older adults and might be more of an issue for H3N2 viruses and H1N1 viruses. And there are other things related to timing too that we need to think about. We want to avoid missed opportunities to vaccinate. If somebody goes away and we don't vaccinate them in August, do we get concerned that they don't come back, for example? And there are also programmatic issues with being able to plan a campaign. Ideally, people should receive flu vaccine by the end of October. And so this is a really great time to get vaccinated. We're well ahead of when the season would peak. Also important, though, that people know things get busy. If they manage to miss October, it's not too late to get vaccinated after that. Getting vaccinated December, even January, can provide important protection, since the flu season tends not to peak until usually January or later. Lastly, just a little bit on the importance of influenza vaccination and why we recommend it. First is that it can keep you from getting sick with flu. It can reduce the severity of illness in people who get vaccinated but still get infected with influenza. It reduces the risk of flu-associated hospitalizations. And it's a particularly important preventive tool for people with some chronic health conditions who are particularly susceptible to getting very sick if they get the flu, and more likely to get hospitalized and more likely to die. Flu vaccines can also be life-saving in children. In addition to helping protect pregnant people, flu vaccine given during pregnancy helps protect the baby for flu for several months after birth, which is particularly important because we don't have any influenza vaccines that are licensed for under 6 months of age. So those babies can't get vaccinated for a good number of months after they're born. Finally, getting vaccinated can help protect people around you who may be more vulnerable to serious illness. For example, those babies who are too young to get vaccinated themselves, older people, and people with some chronic health conditions. Benefits of vaccination have been estimated by the CDC annually for the last several years. We know that the vaccine effectiveness of flu vaccine varies. It's affected by a number of things, including, for example, the predominant viruses circulating that season, the degree of match between circulating and vaccine viruses, and also the age and immunity of the recipient. In a season during which most circulating viruses are similar to those represented in the vaccine, we can generally expect about 40 to 60% effectiveness overall, but there'll be some variability in different groups in the population within that range. For example, generally, the vaccines are more effective for older children and younger adults than for older adults. Generally, they're more effective against influenza A, H1N1, and influenza B viruses than influenza A, H3N2 viruses. But it's important to note that even in a season where we have moderate to low effectiveness, vaccination still provides important benefits, even in a season like that. And just an example on this next slide. So CDC estimates VE through the US Flu VE network, which is a network of 5 sites that have been providing annual VE estimates for influenza for a number of years now. And for the past several years, CDC has also made estimates based on these VE results and what we know about the percent of cases that actually get tested and the characteristics of the tests and how likely they are to pick up flu, use that information to model estimates of the overall influenza burden and the burden averted by vaccination each season. The most recent of these estimates that's available is for 2019-20, where we had overall 39% effectiveness of vaccines. That's sort of at the lower end of that spectrum of 40 to 60% that I mentioned earlier. But even with that protected us from an estimated burden. It averted an estimated burden of about 7.5 million illnesses, 105,000 hospitalizations, and 6,300 deaths. It's important to get a vaccine every year. And one reason for this is that flu viruses are constantly changing. So flu vaccines are updated from one season to the next, as we mentioned earlier. And basically they'll be updated to represent the viruses that surveillance data and research suggest are the most likely to be the most common during the upcoming flu season. The other reason for annual vaccination is that, as we mentioned earlier, protection from the vaccine can decline over time and wane. So yearly vaccination is needed for the best protection. The last slide just has some helpful links, and if these get distributed, these will hopefully be helpful to you. They include links to FluView, both the weekly report site and FluView Interactive, where you can actually make some custom graphs from some of the data that's available from the surveillance systems. Some guidance on antiviral use, which we didn't have time to cover today. The ACIP General Best Practices Guidance, which has a bit more detail on co-administration of vaccines in general. And then 2 links to COVID-19 vaccination resources that should be very helpful this season. Thank you very much.
Thank you, Captain Grohskopf, for that information. We will now turn to Dr. Sircar, who has a PhD in epidemiology and is commander in the U.S. Public Health Service. She is part of the CDC COVID-19 Response Core Clinical Unit and a subject matter expert on underlying medical conditions. When not working on the COVID-19 response, she's an epidemiologist in asthma and air pollution. I will now turn it over to Dr. Sircar.
Thank you, and I am going to share my screen. So thank you so much for having me. We're going to switch topics slightly and looking at underlying medical conditions, which are mostly chronic and non-infectious conditions. As Captain Grohskopf mentioned, that there is a lot of overlap with those underlying medical conditions that look at cause severe COVID and influenza. However, the literature that we reviewed for this presentation is focused on COVID. So as a transition, just a reminder of our recommendation for COVID-19 vaccine boosters of the groups that are where it is recommended for, including those who are 65 years and older, those who live in long-term care settings or a high-risk setting. And at the last recommendation is our topic for today, and that's underlying medical conditions. So let me just start with an overview of what we know of risk factors of severe outcomes due to COVID-19. So COVID-19 does not affect all population groups equally. Age, by far, is the strongest risk factor for severe COVID-19 outcomes. And really, people over the age of 65 account for more than 80% of COVID-related deaths. Larger number of underlying conditions increases the risk for severity. So it's not just having certain underlying conditions, it is having more than one of an underlying condition. And then there's some chronic conditions that occur more frequently or at younger ages in racial or ethnic minority populations. So this is kind of a way of saying that there are a lot of interwoven risk factors, but they're all highly related. So age, race, having an underlying condition or multiple underlying conditions. But when you look at underlying medical conditions, there are also some things that you need to consider, not just the underlying, which condition it is, and there's a growing list of underlying medical conditions, but the number of it and the severity, or if it is controlled or not. Also for this talk, I will be focusing on the adults, and the literature that was pulled for this reviews that we are going to refer to is strength of association, is a lot lower in children. So what do I mean by severe outcomes? So severe outcomes defined as having hospitalization, intensive care unit admission, invasive mechanical ventilation, or death. So we are actually this week in the process of updating our webpage with some new underlying medical conditions. And so some of the things that I will present now, they're not on our webpage yet, but hopefully by the end of the week, they will be there. And those conditions will be in blue. So on our webpage, we do have the complete list of underlying medical conditions. I should say that it's not a comprehensive list. It is what we learned from the literature. And I will talk a little bit when I talk about methods on why it might not be all the ones that can be associated with severe outcomes. But it is in alphabetical order, and you'll see it's also by study design. And we use a study design as an indicator to share of how much we know about that condition, how robust the evidence is for each of them. In the first few slides are the ones that we know the most about. So here is, of course, top by alphabet. Cancer, cerebral vascular disease, and chronic kidney disease have already been on our condition. We expanded the list of chronic lung disease just because we asked a lot of questions about specific lung diseases, including interstitial lung disease, pulmonary embolism, pulmonary hypertension, bronchopulmonary dysplasia, and bronchiectasis. A COPD was on our list, but we did another review under chronic lung disease. In addition, we also added more information on chronic liver disease. We also did a robust review on trying to distinguish some of the other ones, some of the individual ones under that category, because we got asked many questions about this. So it's not just chronic liver disease anymore, it includes cirrhosis, non-alcoholic fatty liver disease, alcoholic liver disease, and autoimmune hepatitis. Diabetes mellitus and heart conditions were already on the list. And we also, this time, are also adding mental health disorders such as mood disorders, including depression and schizophrenic spectrum disorders. So as you can see, that our list also includes some very prevalent conditions, such as obesity, heart disease and diabetes mellitus, and it has a strong body of evidence to support both of those. So another addition is tuberculosis, but I do want to point out that both obesity and overweight is also on this list to add to those to that list of conditions that are very prevalent. So between diabetes, heart disease, and obesity and overweight, and this list does cover a lot of the US adult population who have some sort of underlying condition. So this is near the end of our list that's on our website. And as you can see, these are now getting to some rarer conditions. And sometimes the sample size of these studies are so small that there are fewer studies that can be said that can just on the topic. And so we put this under a different category of case studies, just so that we can reflect on what is known in the evidence. So a quick overview of the methodology. So we have been doing this reviews pretty much since last year, when we did our first review was completed in summer of 2020. And we first went to the literature and looked and based it on reviews that the literature would do. But now we've been standardizing our approach a little bit more and doing some robust reviews at CDC. And we are looking at all 4 of those outcomes that I have listed at the beginning. By no means is this an exhaustive list of underlying conditions. One is we're likely to miss rare conditions just because it takes a long time to gather the information on rare conditions and to write something conclusive or present it in the literature. So most of those, we've reached out to many clinicians and medical professional organizations for rare conditions to see what they've gathered. And as they learn, they will share it with us too. And again, it also means that somebody's actually doing a study on that condition. And that's, so if somebody is not doing a study for example, asthma and COVID, we will not get that information because it's not, most of the information we get from this is pulled from the literature. And as you will see on the website, we categorize this into 4 groups based really on what is known on the evidence, just so that you can, somebody reading it can get a sense of how much is known on that topic and where there might be gaps. So the 4 categories are meta-analysis or systematic review, observational studies, including cohorts and case control, case series or case reports, and mixed evidence. And a lot of those ones under mixed evidence were, for example, chronic liver disease. We are now trying to go through that evidence and really, they're really big categories, and we want to figure out which one of those under mixed evidence shows some evidence of it and which one doesn't, so that we can be more informative. So this is kind of an overview of the list that we have. And I just want to talk about what we know about underlying conditions in general. So what we also feature on our page is a paper published earlier this year by Companions et al. It is a study using the premier healthcare data, which represents approximately 20% of all inpatient admissions in the US since 2020. It is a cross-sectional study of about over 500 100,000 adults hospitalized for COVID-19. And it includes both inpatient and hospital-based outpatients and laboratory diagnosed COVID-19 patients from March of last year to March of this year. The outcome for this figure and the next figure is death, although the paper itself looks at hospitalizations, ICU admissions, sorry, no hospitalizations, just ICU admissions and mechanical ventilation, invasive mechanical ventilation also. So the first part in green you can see is age. And at the top is our reference group, which is those 18 to 39. And it goes in categories of age all the way to those 85 over. As you can see that the strongest risk of strongest association with death is in those 85 and older with a death risk ratio of over 10. In those and the 40 to 49-year groups, the risk ratio is 2.2. Now, we did select some comorbid conditions at the bottom, and we just highlighted a few, those that are really prevalent in the United States, including obesity, diabetes, chronic kidney disease, COPD, and neurocognitive disorders, and other heart disease. And as you can see, their risk of association is in a 1.3 kind of range, which is relatively small compared to age. So age is still our greatest risk factor. So we also looked at number of conditions, and that paper also looked at number of conditions. And this is a graph of what they found with number of conditions and death. On the top is our reference group of having no conditions, to having one condition, 2 to 5 conditions, 6 to 10 conditions, and over 10 conditions. And as you can see, there is the relationship grows with the number of conditions, with those who have over 10 conditions have a hazard ratio or death risk ratio of 3.8. Now, I noticed in my slides that I missed one slide that it is on our website right now. And it is from a study on called Williamson et al. That actually looked at severity of conditions and looked at hazard ratio by severity of condition, or if that condition was controlled. And it did show a relationship with those that those who had uncontrolled or more severe disease had a higher risk ratio than those who did not. And I apologize that that was not, I left that slide off of my presentation, but it is on our website. So in summary, going back to our overview, age is the strongest risk factor for severe COVID-19 outcomes. There is a large group of underlying medical conditions that does increase risk, and we are just updated our web pages to put a few more on that list. Risk increases with the number of underlying medical conditions, and if the condition is uncontrolled or of severe risk. So that is all I wanted to highlight today, and thank you.
Thank you, Dr. Sircar. We will now turn it over to Dr. Jorge Mera. Dr. Mera is the Director of Infectious Diseases for the Cherokee Nation Health Services, the largest tribally operated healthcare system in the United States. He has been dedicated to organizing the Cherokee Nation HCV Elimination Program and the HIV/HCV Extended Care Health Outcomes Project. In the last 18 months, Dr. Mera has been actively involved in the CNHS COVID-19 response and developing the Cherokee Nation Respiratory Virus Surveillance System. Dr. Mera completed his fellowship in infectious diseases and clinical microbiology at Baylor College of Medicine in Houston, Texas, and is a board certified by the American Board of Internal Medicine and Infectious Diseases. He is a clinical assistant professor in the Department of Internal Medicine of the Oklahoma State University Health Sciences Center and a fellow of the American College of Physicians. I will now turn it over to Dr. Mera.
Thank you for the introduction and for the organizers inviting me today. So as mentioned, I will be covering the Cherokee Nation Influenza season 2021-2022 preparedness. And I just want to mention that I'm not going to focus too much on the vaccine component, although I'll mention it, because the challenges that we face this year in Cherokee Nation in particular actually will not affect our vaccine services as much as our clinical services. And I want to focus a little bit more on that aspect. And the reason being is that we have deployed a robust vaccination program for COVID. So piggybacking influenza, actually, it's probably easier this year than years before. And I will divide my presentation into a little bit of information of influenza and American Indians, Alaska Natives, and the influenza provider survey and training that we just performed a month ago, and our surveillance and action plan briefly at the end. So it is important to mention that Native Americans suffer a high burden of mortality and morbidity due to influenza. And in the last 4 pandemics, starting in 1918, Native Americans have had the highest mortality rates related to influenza compared to non-Hispanic whites. If you look at the 2009 H1N1 pandemic, mortality was 4 times higher. You look at seasonal influenza, between pandemics, it's been 2.7 times higher. And now that we have COVID-19 on board, it's worth mentioning that the mortality is highest in Native Americans compared to other races and ethnic groups, 2.4 times higher compared to non-Hispanic whites. And the question is, are Native Americans, do they have a genetic predisposition that puts them at higher risk of mortality? Or by being a Native American, is that a surrogate marker for other conditions like more comorbid conditions or less access to healthcare that puts them at that higher risk of mortality? And unfortunately, there's not a lot of studies trying to address this question. I'm just showing you here in the table on the right side, a case control study of risk factors for death from H1N1 across 5 states, in which one of these states was Oklahoma, where the Cherokee Nation reservation is located. What these authors found was that being older than 45 years old, having pre-existing medical conditions, smoking, delayed use of antivirals in relation to symptom onset, and barriers to healthcare were all associated with higher mortality. But when they looked at AIAN race, that independently was not associated with death. Now, it could be that it truly is not an independent factor, or it could be that the study was not large enough, and they only had 52 Native Americans in the 381 patients they used. Nevertheless, it's a very well studied. The important thing, though, is that there are modifiable risk factors like smoking or immunization, like vaccines, that were thoroughly discussed by the previous 2 presenters, and prompt medical attention that can be improved to decrease mortality in Native Americans. So there are several layers of disparities that Native Americans face in general. First, there's less vaccination rates in Native Americans compared to non-Hispanic whites. They unfortunately have higher rates of comorbidities that are listed in this table. And last but not least, public funding to IHS on a per capita basis is lower than other federal programs like Medicare, Medicaid, or the VA system. So going to Cherokee Nation is located in Oklahoma. It's in the northeastern part of Oklahoma. And on the right-hand side, you see a map of the 14 counties that belong to the reservation. The little red crosses are the outpatient health centers that Cherokee Nation has, and the H here in Tahlequah is the hospital that they administer. And we're the 2nd largest tribe in the US after the Navajos, and but the largest tribal operated health system. So at the beginning of this year, in the middle of COVID surge, we decided to start planning for what would happen if we did have influenza outbreaks or epidemic this season. And the first thing we did, we partnered with Prime, which is an educational company. We designed a survey to ask our providers and nurses and other health personnel several questions about influenza. So that way we planned educational webinars that we already completed a few weeks ago, the last one. So the survey involved 122 health professionals that responded it. And then we had 2 one-hour influenza webinars focused on American Indian and Alaska Natives, and 132 health professionals attended the first webinar and 84 the second one. So for this venture, we partnered with the North Portland Area Indian Health Board, in which we did the same activities in that area of the country. But the bottom line was to do the survey, review the survey during the webinars with the providers and the nurses, and then trigger live team-based discussions so we can develop action plans for this potential influenza season. And later we'll evaluate what happened with those action plans. During the webinars, we presented all the clinical guidelines regarding diagnosis, treatment, and decreasing barriers to healthcare access. So in a nutshell, we 122 providers and nurses answered the surveys. The majority were nurses. The majority belonged to the primary care area, and the majority were in outpatient health centers. 30% were done at the, 22% were in the hospital. And some of the, just to give you an idea of the type of questions we tackled with this in this survey was how comfortable they were differentiating COVID-19 from other respiratory diseases, what type of tests were they using for influenza, what was their turnaround times, if they were using tests at all in previous seasons, or they were just going by clinical diagnosis, and what barriers were they finding in accessing patients or seeing patients that were sick. So in one of the questions of the survey, it was important that we found that 60% of the individuals answered that they agreed that Native Americans were at high risk for serious illness from influenza. But there still was room for improvement, since 34% were neutral and 7% actually disagreed on this concept. When we asked them about their confidence in identifying patients at high risk, the majority felt very confident, but there still were 37% were moderate and 3% were low. So there was room for improvement there. When we asked them about what were their greatest challenges diagnosing influenza, and interestingly, but not surprisingly, 70% answered that it was differentiating it from other diseases, including COVID-19. And this brings a real challenge this year. And it was mentioned by one of the presenters that, previously it was very reasonable to do a clinical diagnosis of influenza in the middle of an outbreak or an epidemic. But with COVID-19, it's very difficult to tease them apart, although there may be some clinical hints. When the surveyors were asked about the top system level barriers, that was spread out across the board, but patient refusal to be tested was the highest one, then slow turnaround time for test results, limited options for different types of tests that they had access to, and inconsistent mechanisms to communicate these results to the patients and get them in for a timely treatment. When they were asked about which test they were using, the majority were using rapid antigen tests, and we know that IDSA and CDC and other institutions recommend a molecular testing. So we thought this was a good moment to see if we could change this. And then when we asked them about what percentage of patients actually access the health system within 48 hours of being symptomatic, because that's kind of the magic number for best treatment efficacy, although it's not that strict. For half of them said that about half of the patients would be seen within 48 hours. So there also is a room here for improvement to see if we can have patients access healthcare a little bit faster when they get sick. So that brought us to the discussion of telehealth, and we have had a lot of experience in the last year and a half with telehealth due to COVID. So we kind of reviewed the benefits and the barriers, and how would they incorporate influenza into telehealth like they did with COVID. So interestingly, the majority answer, the answers were widely distributed, but if you start adding anything related to technical or technology, you can see that the majority of the barriers are linked in one way or form to access to technology, or to managing technology, or to the efficiency of technology. And then when they were asked what how confident they were actually using telehealth, about 30% were very, very confident, but 40% were in the middle and 30% were on the low end. And so there's a lot of room for improvement in this area. So finally, I'll briefly cover our surveillance plans and our action plan. So about 9 months ago, in the middle of one of the COVID surges, we decided that it would be great to have our own respiratory virus surveillance system, since there are great national and some good state ones, but sometimes the information doesn't get to us in a timely fashion. And sometimes there are differences. We notice by observation what's being reported and what we are actually seeing. So we did get some funding to establish our own surveillance sites, and we have established that we will roll out with 5 sites. You can see on the map, the red circles are where in the outlying center where the testing sites will be. And these sites will be equipped with multiplex PCR for respiratory viruses and staffed with dedicated providers for surveillance. And we'll have information technology, extract laboratory and clinical data that will be, that this will feed the infectious disease department that will analyze the data and then produce reports that will be given weekly to our public health department. Cherokee has its own health administration and medical providers in the health facilities. And we expect these reports to cover the start and end of influenza season locally, beyond what we know from the state health department. Trends of different respiratory viruses, the association of these viruses with clinical presentation, severity of viral infections, and rates of influenza-like illness. And when we detect signals of imminent or established respiratory virus outbreaks, this will trigger the rapid infection control team from our own public health department, and to begin immediate investigation, containment, and site active surveillance activities. And of course, to notify our state health department and our CDC, depending on the nature and the type of outbreak that we are seeing. So the survey, which is what I just showed you a sample of the questions that we asked for time reasons, but the bottom line was that our providers and nurses had intermediate to high perceived level of community influenza preparedness, that the majority of patients do come after the 48 hours after they're sick, that the major barrier for identifying a positive influenza test was refusal from the patient's end, which is interesting, and we need to explore that a little bit more. That the majority of the providers were confident in identifying high-risk patients for influenza complications, including IAN, American Indians, Alaska Natives, and that rapid antigen testing was the primary method used, and we started switching to molecular based on that information. And also the technology needs to be improved, either the access or the type of technology for health, telehealth to be available for influenza in a more precise way. So we asked all of them to develop their own plans. We have 8 outlying clinics. Each outlying clinic is a different world in itself. So we know that we just need to give them directions on what are our goals, but have them develop the plans on how to tackle those processes. So this is the summary of our plan as of today. It's still a work in progress. So education of providers and nurses have been completed by October 1st. Vaccination efforts for influenza and COVID-19 are ongoing. Both vaccines are being offered in all the Cherokee Nation health centers. And I think we have a robust vaccine delivery capacity, especially this year. Regarding diagnostics, we've already switched to nuclear testing, to NAT testing for influenza in the 8 outlying clinics. We're still working on our urgent care and ED. And the hospital is equipped with multiplex PCR, and that's been for years now. And so we have a good idea of what type of viruses we're admitting in the hospital. But the main barrier we are seeing is that we don't have availability of the 3-in-1 test, meaning the test that with one swab you can detect RSV, influenza, and SARS-CoV-2, and that would be very valuable to have. and we're working on, I don't think we'll have it for this season, but maybe for next season. And regarding evaluation and treatment, so plans are being developed at the clinic level, and that's very important for us because we want them to come up with their best solution, which I think it works out better at the end. Try to adapt what we developed for COVID, to adapt it for influenza. We already have 4 clinics prepared for that are actually delivering COVID monoclonal antibodies, and we're checking our stock of influenza antiviral agents to make sure we have enough if we happen to have a big outbreak of influenza or a big epidemic. Deployment and intensification of resources will depend on our respiratory viral surveillance when we have that available. And we are now planning for a public education campaign to let individuals know in the community the problems with influenza, vaccination availability, and also to try to reach us as soon as they can if they get symptomatic during the winter or the fall. And that is it. Thank you.
Thank you to all the presenters. We will now go into our Q&A portion. Again, just a reminder, you can type your questions in the chat box or in the Q&A box. We do have a few questions to begin with. So the first question, and I'll leave this open to whoever wants to answer. Will the new COVID treatment pill work for influenza like Tamiflu?
No, I do not believe so.
Okay. Then our next question, 1 second. Since RSV can cause more severe infections, are you encouraging your patient population most at risk to get boosters? And I believe that is for Dr. Mera, that question.
Well, I believe we do not have RSV vaccines. And so I'm not sure if that was booster for.
I think they meant the boosters for the COVID vaccine. Are you encouraging?
Oh, okay, for COVID. That's interesting. So we're a little bit split on that. It's been a little bit controversial when you look at the data. And so basically what we're doing is if anybody comes to our system and asks for a booster shot and they meet the criteria that CDC has put out on their webpage, we will give them the booster vaccine. And we've had a lot of people requesting that and we've been delivering it. Now the question is, do we have enough data to know if boosters work? I think that's a little bit controversial at this moment. And we would advise the patient on a case-by-case basis until we have more information. But we are giving it and following CDC recommendations for the indications.
Okay. There is a follow-up to that. Can RSV infect the same person more than once?
And the answer is yes, it can.
Okay. We have one more question. Has there been any movement on the booster for those who got the Moderna and J&J vaccines?
Could you repeat the question? Has there been
any movement on the booster for those who got the Moderna or the J&J COVID vaccine?
I know that they have submitted for FDA approval, but I'm not sure. I don't think that approval has been granted beyond the Pfizer vaccine yet, but I'll let the other speakers, maybe they have more information on that.
That is my understanding also for both Moderna and J&J.
There's a follow-up question for that. Do you know if there's been any mention of crossover, as in those who got Moderna or Johnson first could now take the Pfizer booster?
Not that I'm aware of, but I do on the next ACIP meeting, or the ACIP meeting, my understanding that there is some data that might be available and introduced. But I would go look at what's on the website to confirm, but no.
Thank you. It looks like we don't have any additional questions. So I want to thank everyone for joining us this afternoon, and I would like to thank our speakers as well for taking time out of their busy schedules to share this important information with us. As a reminder, please complete the evaluation, which will be sent out to you via email later on today or tomorrow. And also be on the lookout for the recording as well as the slides. Those will also be sent via email, and they will also be available on our website one day next week. Again, and thank you for joining us.